after all of this discussion, we spent a fair amount of time thinking about how could we make sure that we tried to wrap things up. One of the things that got thought about early is we could have all 406 of you turn your video on, and then we thought that that probably was going to be unworkable. So in fact, what we've done is we've asked a number of people to join us to serve as, to a certain extent, audience surrogates, to reflect on what they've heard over the last 2 days. I'm going to push them with some questions and to try to have a general conversation over the next 35 minutes to try to wrap things up and see if there are any conflicts that we may not resolve or consensus that we can resolve. So I wonder if Diane Myers, Cynthia Carter Perrilliat, Mildred Solomon, and Abraham Brody can all turn their cameras on. They are all extraordinarily distinguished in their day jobs and have spent the same amount of time watching the first session and now watching this session. And so their job is going to be, I'm going to ask them to just spend maybe 2 or 3 minutes if they have some take-home reflections, and then I have a series of questions, and then I'll get to the 405 participant questions that they may want to ask you. So I'm just going to start and go down on my screen from top to bottom. Ms. Perrilliat, can you start? I wonder if it's okay with everyone if I just call you by your first name, so we sort of try to make things more similar for everyone. Cynthia, would you be willing to start?
Thank you, Bob. I'd be happy to start. I think first and foremost, I'd just like to comment on just how incredible these last 2 days discussions have been. We've heard from various approaches, certainly the medical, the research portions, obviously. I love the patient advocacy portions, ethics. It's just been an amazing conversation. So I first want to just thank the team for putting this together. I think overall, there are some really key things that have stood out for me. I think first and foremost, we could all agree that this advanced care planning conversation is one that's tremendously complex. It has various levels. It has various waves and moves, if you will, from so many different angles. But certainly, I think we can all agree it is really a very human issue. And that humanity, the human-centric ness of this space, I think many times is overlooked when we come from a medical scientific perspective. And of course, we recognize the importance of that because we're dealing with patients and families, many times obviously seriously ill, frailty and so forth, fragility and so forth. So I think overall, recognizing the complexity of this, I think Dr. Rebecca Sador certainly pointed that out very clearly in our first sessions. But I'd also like to call out Mo Stewart and Y. Harris. I really appreciate those personal experiences also that really got to the complexity of the gathering of information and how systems are not communicating with one another to really communicate within. Obviously, that's a very central and very challenging subject as well. So there's much to say, and we have other panelists, but I think I just want to call out the complexity. Certainly has been highlighted. It's a very human-centric issue, which I think adds to that complexity, but it also brings me a sense of, how shall I say, appreciation for this space. Yes, there have been 30 years of work and research that have gone into this space, but I leave this space saying that we need to continue even more and even more effectively based on the things that we've learned, our learnings, and the fact that we really need to approach this subject from a human, whole person, truly person-centered approach. And I can speak more to that as we continue our conversation.
Thanks, Diane. You're on mute.
Thanks, Bob. I want to echo Cynthia's vote of thanks and appreciation. for the quality of the presentations and the thinking that we've heard both today and last week. But I'll tell you what I'm left with, and I'm reminded of learning about Maslow's hierarchy. And the most important thing in Maslow's hierarchy is access to food and water and shelter. And Rebecca's data shows that many of our families are not confident about any of that. They are rightfully worried that a serious medical illness will bankrupt them and hurt their families. They are rightfully worried that there's no one to take care of them at home, and that their only option if they're in a crisis is to call 911. And so it feels to me as if those of us working to advance care planning are off in our little corner focused on maximizing patient self-determination and autonomy, and reality is over here on the other side of the room. And our faith in this illusion of control about what happens to people with serious illness causes us to focus on things that are really not at the top of the priority list for actual patients and families. What's at the top of the priority list is not being bankrupted, being able to pay for their kids' education, being able to put food on the table, being able to get help at home if they're caring for a seriously ill loved one. And we have a healthcare system that doesn't enable any of that. We have a society that doesn't enable any of that. And so I just it also reminds me of that old joke about you dropped your eyeglasses in the parking lot, but you're looking for them under the street light because the light is better. So the patient's problems are in the dark parking lot, and we're trying to address their problems under the street light, which is advanced care planning. And as a field, I think health professionals have a larger humanistic vision, as Cynthia was describing, and we need to embrace that larger humanistic vision and push for a reallocation of healthcare resources to meet actual human needs. So that is my brief summary.
What I'm hearing you say is that advanced care planning shouldn't be a priority until we solve larger social problems regarding healthcare. Is that?
Basically, a lot of effort, money, time, 30 years of research has gone into trying to perfect advanced care planning. Many people's careers have been devoted to advancing advanced care planning. With very little moving of the needle to be shown for it. And the real problems ever worsening are not in that room.
Okay, Millie, thank you.
Well, Diane and I often follow each other. Remember when we did this in Aspen, and our ideas are very, very similar. She just put it more beautifully in a better organized way than I probably will in the next moment or two. You know, I think I agree, these have been 2 days of great conversation. But I share this frustration that we have been doing this for 30 years, using the tools and talents that are mainly medical to solve a mainly social, financial, and political problem. And so I don't think, Bob, I don't think the takeaway is we shouldn't do advanced care planning until we've solved the bigger social, political, and financial problems. I think we have to do both. And I heard some very exciting systems-oriented approaches to making sure that advanced care planning conversations of the right type occur with the right sets of patients. And I want to say a few more things about that, what goes on inside the clinical setting from a systems approach. That was very exciting, especially this last session where systems made public and visible to us how they're doing that. But this larger question, of the dark parking lot, I think it's not that we should wait until the lights are on in the parking lot. I think we have to all ask ourselves as citizens, not just, you know, if we're acting in our professional roles as bedside clinicians, there's only so many tools available. And so, of course, we talk about treatment decision-making and advanced care planning at the bedside with individual patients and families, because that's what caregivers do. That's the tools you have available. It's the setting in which you are located. But I think that this larger point about the social and political will to provide the support that an aging population requires is really a citizenship question. And so that's why we can do both at the same time. We can enhance advanced care planning in systemic ways if we get smarter and more organizationally oriented. But I think that since healthcare professionals are highly esteemed, since they know these issues closer and close hand more than anybody else, there is a citizenship role that we can all play as well to try to put in place the kind of society that we want to be, not just the kind of healthcare system we want to be. And so, yes, I don't think it's about waiting. I think it's about doing both in two different dimensions of who we are.
Okay.
Can I just say one more thing about the systems approach? It's more of a question to the group. I feel sometimes when I observe these conversations inside even the very best healthcare systems that I'm kind of observing a conversation that's almost a bit mad in the sense that it's focused so much on asking patient-centered questions without having provided enough frank context for the patient to understand why you're even asking them their preference. There's a Mad Hatter kind of feeling to this. So I've had this feeling for these 2 days that there's a lot of sophistication at better researching how to hold these patient-centered questions with people. But I haven't heard very much until the last session. I was delighted to hear that Penn has a 3-hour training program. That's extraordinary. That's great. That's what we need, because I feel that providers have to be brave enough, courageous enough to describe what Rebecca's mom wanted to know. I think it was Rebecca Kirch. Do I have that right? You know, what's going to happen to me when the other shoe drops? I don't think we're telling people what's going to happen. What is the likely trajectory of my illness? What kinds of things might I face? Here are the choices that you may confront. Here's some of the things for you to consider. There's a lot that providers should be feeding into these advanced care planning discussions. It's not just about asking open-ended non-medical patient-centered questions, but having the courage to tell somebody that they're in the final phase of their life, and this is what it might look like when the other shoe drops. So those are the two things: systems orientation inside in the clinical world, and acting as citizens because of our specialized knowledge to change the political world.
Well, those are hard acts to follow, right? And when we came in here in the beginning of the first 2 days, Bob, you asked the question, or maybe it was Jim asked the question, you know, do we have anything left to discuss? Well, clearly after these last 2 days, I think the answer that you can provide, there's still a lot left to discuss and a lot left to answer. You know, I agree that, you know, when there are such systemic problems within our society, and then you throw in issues of you know, systemic inequities, mistrust in the healthcare system, particularly amongst people of color, and LGBTQ populations as well. And you have 63% that are focused on financial distress, as Rebecca said. How are you going to deal with this other piece? However, at the same time, it's kind of like waiting for Godot. If you just sit there and wait for all of the social inequities to go away, you're just going to be sitting there and waiting. And so there are opportunities to focus on the advocacy for shifting away from a medical environment and putting more of our money into social spending than in the 120 academic medical centers that take up 25% of our healthcare spending, even though it's about 5% of our healthcare people that are being seen, and focus on both how do we get this out there in pragmatic ways to larger communities that really need the opportunity and are taking care of a different set of patients, and even to remove the patient moniker from it. People, you know, when I sit down for an advanced care planning or goals of care conversation, and the first thing I ask is, tell me about yourself. And they start going through their medical problems. And I say, no, tell me about yourself. There's a look of shock because patients are so used to be treated as patients instead of people that we're not getting to what their needs are. And so it comes back to that. And that's where some of these creative models around healthcare workers. So you have work at a University of Colorado that has focused on using healthcare lay healthcare workers, patient navigators to address events care planning, particularly in that study in Latino populations. You have others focused on social workers taking the lead. It's getting outside of this medicalized realm, but then we still have to come back to how do we connect to getting the system to recognize those pieces. So those two pieces have to come hand in hand, and I'll leave it there because I know we have a lot more to get to.
Yes, Cynthia.
Yeah, I wanted to piggyback on what Ab was saying. I totally agree that, and I think we're all saying the same thing, that we really want to look at this issue, again, from a holistic perspective that steps not only works within the medical system, but also outside of the medical system. I think there has to be this congruent approach to really address and attack the needs of community. We heard the statistics about Black and Brown communities, particularly African-American communities, and the disparities that exist. Those of us that are people of color have long known these disparities, and many of us in the healthcare system have as well. COVID certainly has highlighted that. The model that we operate from in the ACCA is one where we train faith-based community care navigators. Is extensive training on not only advanced care planning, but dealing with what health system refer to as the social determinants. So meeting those social needs, housing, transportation, food, issues around how to prepare for a doctor's visit. What kind of questions are important to you so that when you go, as we refer to it, your 15 minutes of fame. Of course, now we're, in the COVID period, but yet through telehealth, the issues remain the same as preparation for the patients. We don't call them patients either. There's so many important issues here to address, but I wanted to just piggyback quickly on, is it AB or AB? I'm sorry. I wanted to say your name correctly. Thank you. I wanted to piggyback because I think it's just really important that we need more hands on deck. Yes, we need the health system, but we also need community to be engaged. So people can be trained to be messengers. But I also should say to you that this is a process. I think we all have learned, if we really want to hear true person-centered care, goal-oriented care, what's important, what values are significant to individuals, we need to have time. And we know that's a commodity, and it's a precious commodity. And so I think it raises this important point that community and trained navigators, I love, I think it was Nina's presentation that spoke about palliative champions. I mean, there are so many levels of participation that we can gain from people that are non-medical also, that can really be supportive in this space. And caregivers, we haven't spoken a lot about caregivers, but the impact that people in community can have in communicating with caregivers so that they too don't have to be a statistic because of the overwhelm that they're experiencing in working with people that have advanced illness. There's so much that can be said, but I will pass the baton to my colleagues.
So I'm going to push you all here. Having listened to the last 2 days, you all gave us new things that we should be doing and how we should change what we're doing. What should we stop doing? Given the data and given what we've heard over the last 2 days, what can we say, this really probably didn't work. We should stop doing it. Diane, I'm going to start with you.
Gee, thanks, Bob.
Okay.
I think the first thing we have to do is to stop conflating advanced care planning with cost savings. Many entities, payers in particular, as well as government, has been persuaded, I'm not sure exactly how, that advanced care planning is the key to reducing spending. And there are no data to support that. And that really worries me. The pressure to push advanced care planning, not coming from respect for individuals or wanting to promote relationships between clinicians and patients and families, but actually as a means of reducing healthcare spending. There are no data for that, and it's a dangerous conflation. So that's number one, is to stop putting forward what we do as a way to improve healthcare value. For the Serious Illness Care Project, the Ariadne Labs data is fascinating in this regard, because the randomized controlled trial showed that there was reduced anxiety and depression in the patients. And I don't know if I can't remember if they also measured sense of feeling heard and understood, sense of being well cared for by their clinicians. But last week, Joe Palladino and colleagues published data showing that it had absolutely no impact on utilization of any kind. So we need to separate those things out. And yet the overwhelming motivation for advanced care planning among those of us who are not in this field is about money. And so I think we have to be really super careful about that.
Other speakers, what should we stop doing?
I think we need to stop traumatizing our caregivers and the people that they are caring for. There are studies out there, multiples of them, that show PTSD symptoms amongst caregivers who have had to go through these complex decision-making processes, all the way from ACP to more immediate goals of care conversations. And part of the reason that I think that probably exists is because we pressure to make decisions right away. And we pressure around what's important to us as healthcare providers and not what is important to the patient and the caregiver. In the end, I might be the one performing CPR, but the person is already dead. If they're dead, they're dead. That's the least important decision, yet it is the one that is brought up the most frequently as the first part of conversation. And so we traumatize them into trying to make these bivariate decisions that don't need to exist and aren't important to them, versus the real issues around who is this person, what was important to them as a person, and how they would want to live. And so it's changing the frame of what we are currently doing and throwing away this focus on us and what we are going to be forced to do by indecision, and making it about them and what is positive about the decisions that they are making.
Other comments?
In a way, my response is going to be almost the converse of ABS. So I think one thing we should stop doing is worshiping autonomy. And the whole focus on advanced care planning is an instantiation of American fascination with individualism. And instead, the way I think this might be, I'd like to know what Ab's thought is about this, because it's maybe contrary to what he just said. I think we should be focusing on beneficence and care and justice and accountability of the clinical staff to, I'm sorry about this, I'm trying to turn it off. Accountability of the clinicians. I mean, Ab, you just said it almost the opposite, that we should put it about the patients. I'd like to put it about the responsibility and accountability of the healthcare system to make sure that there's some sort of integrated care, that we're just not putting people on a default pattern of specialist care without anybody integrating all the different specialists and finding out how to make an integrated plan. I feel like there's no one in charge. There's no quarterback, as people say. So I'd like to shift from this, we're gonna, this autonomy focused thing to a systems oriented thing that says, what are the responsibilities, obligations, and accountability of the healthcare system to offer something more than a default chute into fragmented specialist care.
And
I
I
would
don't see
jump
this
in.
as diametric. Sorry, Cynthia.
They're probably complementary, but you emphasize different aspects.
Yeah, I just wanted to jump in really quickly in response to that question, Bob. What should we do differently? I guess I'm reflecting on the definition of insanity that we've all probably heard, and that is that doing the same thing over and over again that we know is ineffective, basically. And I think, given what we've heard, the data, the research, the studies that we've read and heard about for years, and of course, the studies and research that we've heard in these past 2 days, I have to be very candid and say, I think there's a touch of insanity that, and I'll embrace it personally, if I continue in a mode that says we need to approach people as individuals. We need to consider how we've spent dollars. And Diane, I think you hit the nail on the head when you spoke about a reallocation of resources. I think that we can clearly say that there needs to be a different approach. I come from a marketing communications background. My undergrad is in marketing. And I think there's something really important. We all recognize the importance of communication and language in this space. I really think that we need to step back and do an overall assessment. And certainly the health system partners are important players in that. I think our research partners, obviously, we need community leaders to be a part of this. We need caregivers. We need quote unquote patients. We call them persons needing care in this space. And I'm sure there are other, obviously other important players and stakeholders that need to be in this space. But I think we need to develop what I would refer to as a multi-tiered marketing strategy. And I think the strategy should be layered such that there's a congruent effort that happens in the health systems, which is an important player in this space, within communities, which is an important player in this space, but also a national campaign that includes language and messaging that speaks to the masses. There needs to be a reallocation of funds that really embraces this as an important human-centric initiative that is going to impact every single one of us, whether we're in healthcare, whether we're hospice, palliative care, you name it, we're all human beings, and we're going to have to deal with the issues of making decisions about what we want or don't want as we approach life. And it has to be an approach that speaks to not just serious illness and end of life, but empowering the voice, empowering people to know that what they want for themselves counts. So I would say we just have to, I think it's insane if we continue the same stuff that we've done. We've got enough data and information that tells us that there needs to be this multi-tiered approach, but we need people to come in that are, and this is not a no dig at any particular profession, but we do need marketing minds, people that know how to craft language and messaging that can really hit the nail and address all the issues that we know are important. And again, I have to keep coming back to the human-centric, true person-centered approach. And I think we'll find that communities of color will embrace this notion of having individuals trained that can take the time to hear their stories. We have to embrace storytelling and story listening in this space.
So
and
I want to ask a question about that. Miller, if you look at the medical literature about personalized medicine, it really refers to genetic profiling. And so my question is, given that our fascination with science to a certain degree, and with personalized medicine, how do we make the changes that Diane and Cynthia and Ab are calling for in a society which seems to both want time and personalized care and yet seems very fascinated with every advance that it can find?
Well, that's the that's the $64,000 question, right? You're raising the whole power of the technological imperative and its hold on our imaginations. But I think there has been progress made. In his opening remarks, Bernie said he thought that there'd been more acceptance of surrogate decision-making. He was going way back to the Karen Ann Quinlan case, where it was a question as to whether her parents could, the request to withdraw the ventilator would be accepted by her surrogates. And so Bernie and I have a long view. I shouldn't brag about that, you know what that means. And so it's possible to see progress. I think we're on the cusp of doing better. I think that these 2 days have shown an awful lot of research that has been very nuanced. And I think I really just think we need to shift to having this be a systems change with accountability and responsibility for the care providers to be able to describe what happens when the other shoe fits. In other words, to be able to describe trajectories. I think that our citizens and the people who need care want to know what's likely to happen to them, but it's not being revealed. And so they're being asked their preferences in a vacuum without understanding what their actual situation is. I don't think that's inconsistent with personalized medicine or a focus on genomics. I think it's orthogonal to all that. It's a different matter. And we need to look at the language of the clinical care team as much as we need to look at the readiness of the patients. And I'd like to see more of a shift in that direction towards the accountability and obligations that the system has.
Diane, you had raised your hand earlier. I want to make sure.
Yeah, I just want to remind everyone, and this is aligned with what we're all saying, is that there are more ethical principles underlying the practice of healthcare than autonomy and self-determination. The other ethical principles are justice and equity, beneficence, doing good for patients by their own lights, doing good in a way that aligns with what they think is good, and not doing harm to patients. And all our focus is on honoring self-determination. And we've let the other ethical principles atrophy in terms of their day-to-day influence on our practice. And I think it has taken us, it has deformed the practice of medicine as we essentially ignore these huge social factors that determine the outcomes of more than 80% of our patients. But we're doing fine if we ask them whether they want to be intubated or not, or who they would trust to make medical decisions on their behalf. Check, check. So some of this, I strongly believe that supporting clinicians to have meaningful conversations with people living with serious illness and their families is valuable because the relationship is valuable, because the relationship creates trust, because the relationship helps the person and their family feel valued as fellow human beings. And I think much of the data that shows positive outcomes supports that belief and that we should invest in it, not because it's going to save us, but because it invests in the all-important relationship, without which no medical care can be of high quality or achieve valuable outcomes. So yes, we should keep incentivizing conversations. I love Jennifer Ballantyne's recommendation here that we turn the street light over advanced care planning and make it focus on everything that is important to the person and their family, including whether they have enough to eat, whether they have transportation, whether they're afraid of violence in their neighborhood, that all of those things are our purview. Not just, do you want a ventilator or not?
Bob, could I
Yeah.
add something? You know, it's easy to criticize medicine and healthcare, but I also think bioethics itself deserves some criticism here. I'll just use the Hastings Center as an example. We're very proud that we published guidelines on the use of life-sustaining technologies, which helped to create the norms for withdrawing or withholding life-sustaining treatments. So to guide bedside decision-making. But about 2 years ago, Nancy Berlinger and I commissioned, co-edited a volume called "What Does a Just Society Owe Its," something like "What Does a Just Society Owe Its Older Members, Its older Americans." And our first essay in that was calling on the field of bioethics itself to kind of do what Diane just said that medicine should do, and to take within its purview not just clinical bedside decision making, important, we're not saying it's not important, but to go beyond treatment decision making, to go beyond our own guidelines that we were very proud of, to look at what a just society needs to do to express its duties and its obligations to all of its citizens. So I think all of us have to kind of move to a population level set of ethical concerns.
So I'm going to ask Cynthia a last question, which is, there's been a lot of conversation about medicine doing this. To what degree is this healthcare's role versus society's role in general? And is there a cost for locating it within healthcare rather than society? Because I've seen us go back and forth about with those two words. You're muted.
Thank you, Bob. I think there's obviously very much a cost to do this right. And I think that obviously, again, healthcare has an important role in that. But I also think that, you know, we need to do more diligence when it comes to the policy level and make policy changes that speak to this notion that we're speaking now about justice and equity and inclusion, and just the significance. I think the hour that we're in presently, if there ever was a time for us to really more fully embrace DEI and add justice to it as well, DEGEDI, some of my colleagues often refer to justice, right, diversity, equity, and inclusion, is now. And so I think it's a societal issue. Healthcare is a leader, and we need healthcare to lead, but we also need to affect this from a policy perspective as well. And I think we'd be remiss if we did not include, discuss, communicate, and engage our political realm in this important subject matter. I could say some things about our political climate, and hopefully, well, we'll see changes, hopefully, but I think there is much to be said about the role that the political realm plays and policy plays in this space.
So it is 28 after, so I'm going to get yelled at. Ab, I'm so sorry that I didn't get to your comment. I want to thank all four of you for your comments. It has been interesting that a conversation that started with a relatively narrow focus about advanced care planning has taken us very far to social determinants of health and politics and policy, and pointing out that if we want some of the things that advanced care planning might have been expected to achieve, at least I've heard from our four speakers, that we need to pay way more attention to these other domains, because the 30 years that we might have hoped that advanced care planning would achieve those things, it hasn't achieved all those things. I want to particularly thank the National Academies of Science, Engineering, and Medicine, and Ms. Gregg and her staff for their amazing work. That this is a project that's been about 18 months in planning and has only come to fruition because of their tremendous work and diligence in not letting us all disappear. We will be sending out information. You will all be able to pull up this material and listen to it, and there will be a summary that will be coming out. that's where it will be available on as archived. I want to thank everyone, as well as the group that asked us to do this, and we hope you all have a great week, and stay busy over the next week. And if you have important things that you need to do over this week, we encourage you to do them tomorrow in a timely fashion. Thank you so much.